All right, it's 8 o'clock. Good morning, everyone. Welcome back to our Cardio-ECHO clinic, weight management and behavior change, cases and discussions. And I think we'll just go ahead. So I'm going to hand it over to Dr. Rao.
Okay, thank you, Jesse. Thanks again to everyone for joining us for the home stretch. And so we have two great cases today, as well as a brief didactic presentation that Jim and I will deliver. And we have our discussants listed. Next slide, Rick. This is our structure as you're familiar with. Next slide. And these are our disclosures. So Chris is one of our discussants as well. You can read his disclosures as well as mine. Next slide. Again, another reminder about person-centered language. We've been doing very well with it as far as I can tell. So next slide. So let's get to the core of our didactic session and what inspired this whole talk and initiative. It comes from direct experience. So we started our Fitter Me medical weight management treatment program in 2018. So it's about 4 years old, almost 4 years old now. And we've seen several hundred clients over that time period, many of whom are doing very, very well. But we did notice that about 80% of our clients are African-American women. And that in some cases, they do struggle to achieve the same outcomes as people in other groups, especially men. Men tend to do well regardless of what ethnicity they're in. And so we wanted to better understand what was actually going on and how to cater to this population. The fact that 80% of our clients come from one specific community, I think it means a lot. And beyond that, I think that it kind of dispels the myth that some groups are not interested in weight loss. There's no way 80% of the population of Northeast Ohio consists of African-American women. It's a relatively small portion. So there's a high demand for our services within this subpopulation. Next slide. So I want everyone to be able to describe the epidemiology of overweight and obesity among African-American women, 3 factors likely responsible, and a peer support approach to tackling obesity among African-American women, which Jim will address briefly as well. So I've been in this field now more than 20 years and started off in 2001 when I did a study on soft drink consumption in kids. And I used to look back at yearbooks and college photos from the 1930s, 40s, 50s, 60s, etc. And this is a photo from a secretarial academy. I believe it's in Mississippi. These are African-American women who graduated from the academy, 1951, 1952, around there. And I often ask audiences when I show this picture, how many women with obesity do you think there were back then? And most of them say, oh, there were probably a lot fewer. And then I respond by saying, not a lot fewer. I didn't see any that had obvious obesity, not one. And this applies to children as well. You show them old school photos, and there wasn't a single one back then. So we know by this measure alone that we're not dealing with a genetic phenomenon. Genes don't change that rapidly. There must be something about the interaction of people in their environment that is leading to such a high prevalence of this problem. Next slide. This is just another school photo, schoolgirls around the same era as well. Similar assessment. If you look at school photos in any group of children today, they look very different. Next slide. So, looking at this from a statistical standpoint, yes, the rates of obesity have increased even over the last 20 years or so, right? And they continue to increase. We're approaching half of Black non-Hispanic women with obesity in the United States. It's a grim statistic. And even more importantly, the number with severe obesity is also going up substantially. Next slide. And of course, you've all seen this slide as well. Compared to any other group, the prevalence of obesity is much higher among non-Hispanic Black women. And interestingly, if you look at compared non-Hispanic Black men, they have a lower prevalence of obesity compared to non-Hispanic white men. Well, it's not that different, but very similar And if you look at Hispanic men, it's not that different from the other groups. Basically, not significant differences among men. Next slide. So before we say that, well, this is something that's inevitable, let's look at some of the research literature. So the famous Look Ahead trial, which was an intensive lifestyle intervention for individuals with overweight and obesity and type 2 diabetes. Impressively, they recruited 31% minorities. Even more impressively, for a weight loss trial, 42% of participants were men. It is notoriously difficult to recruit men for these sorts of studies. The average weight loss was 5% at 1 year in all subgroups. The weight loss was sustained at year 8 in non-Hispanic whites and minority women, but not minority men. So what is the lesson here? That minority women are able to do just as well as anybody else in a controlled research environment. So this is not a physiological phenomenon. It's not inevitable whatsoever. Daily self-weighing was strongly associated with weight loss in many groups, as it is across the population. Next slide. You look at positive deviance analysis. So these are women that were especially successful, and they deliberately selected low-income African-American women. We have found, even in our Fit or Me clinic, we have people across the socioeconomic spectrum from different racial and ethnic groups. And if they happen to be of higher socioeconomic status, they do well, regardless of their ethnicity or race. So that's not real. And you know, across the entire population, there's not that many people like that. Most people are either middle class or come from low income families. And so if you looked at low income African-American women in the Look Ahead trial who had done well and maintained their weight loss for 6 months, there were 3 themes that emerged. One is that they were more highly motivated than others. They had opportunity in terms of time and effort and support, and they were adaptable. You know, if your low-fat yogurt is not available, your preferred brand is not available on a particular morning, then you'll try something else. You have to be flexible as far as things go. Next slide. Weight loss maintenance is an important thing. What is responsible for weight loss maintenance? Inclusion of cultural adaptations resulted in superior weight loss outcomes compared to the usual care. But what are those cultural adaptations? And we're often told that we need to have interventions that are culturally sensitive, that respond to specific needs. And culturally sensitive can be not just in terms of ethnicity, race, language, religion, etc., but even specific types of groups. I mean, physicians have our own culture, right? And we prefer a certain approach. But what are those cultural adaptations requires further understanding. And that's one of the conclusions of this study. And that was one of the things that we endeavored to do last summer. Next slide. So we brought together leading experts in the country, as well as patients and leaders within primary care, family medicine specifically, to try to meet 3 objectives: develop a summary statement which both explains the higher prevalence of obesity among African-American women and also the disparity in success of weight loss efforts between African-American women and other groups. Provide recommendations for family physicians, and that applies to anyone in primary care, to discuss obesity and weight loss with their African-American female patients. They're practical, evidence-based, informed, and culturally sensitive. So many recommendations from obesity guideline committees, et cetera, are just not practical. And so we wanted our recommendations to be informed by people on the front line saying, I've got a few minutes to talk about this. How do I talk about this in a sensitive way that engages the patient and responds to their motivation to achieve a healthier weight? And we also wanted to develop a framework to address outstanding questions related to African-American women and weight loss, and eventually leading to trying to address those questions through research. Next slide. The 4 principal questions that guided the workshop that we held last July: what are barriers to and facilitators of successful weight loss and weight loss maintenance in African-American women? Starting the conversation. So my special interest is in communications. What are culturally appropriate ways to begin to discuss weight loss among African-American women? What treatment strategies are more likely to be successful and can be implemented through or accessed through primary care? And what are the remaining questions that we need to answer? What are our next steps and our summary of priorities and discussions? I think number 3 is probably the most important question. I've often said, based on my experience, that anybody can get somebody to lose weight. If you have a personal chef who's in your house and preparing meals and a personal trainer, and you invest thousands and thousands of dollars, yeah, you'll achieve a healthy weight. And once those resources are gone, your weight will come back. So we need something that can be implemented in primary care, that can be sustained and can re-engage and re-engage patients over a period of time. Those are some of the most important criteria for any weight loss intervention. Next slide. So to give you an idea of the folks we had, so Dr. Werner and I were part of this. My co-leader was Tiffany Powell-Wiley, who is based at the National Institutes of Health, who succeeded me as chair of the American Heart Association's Obesity Committee. I can't remember what year she became the chair, I think 2015. So it's already been quite a while. So she was chair for several years. Tracy Conti, who's now the chair of family medicine at the University of Pittsburgh, a number of community leaders who are very passionate about this issue, including Patty Fears, Mary Douglas Brown from Washington, D.C. Some of you have probably heard the name Shiriki Kumanika, who probably has more expertise in this area than anybody else in the country. We had a number of family physicians and family medicine leaders, as well as patients. What we did not have are patients who come from lower income groups, and that just happened to be the timing and our ability to recruit them. So both of our patient representatives are very, very successful African-American women in the higher socioeconomic strata, but nevertheless, I think had some very meaningful insights to provide to us. Next slide. So I'm going to turn things over to Jim, and he's going to talk about what we found.
Okay, thank you, Goutham. Yeah. This is an incredibly important issue. And we've seen about 600 overweight and obese African-American women so far in our clinic, and it's often perplexing for us. And this was really driving us to learn more and find better ways to serve this population, which is often underserved in this area. So next slide. So the primary reason that African-American women have the highest rates of obesity in our society, and they're the segment with the highest rate, is that they have greater overall exposure to obesity promoting factors than most segments of the population. So we simply are exposed far more to factors that promote obesity and being overweight. And these include social and economic and environmental factors, discrimination, of course, and high rates of poverty. And African Americans are the segment of our population with the highest rates of poverty as well. So it's about 20% of African Americans are in poverty. So this is a very important factor, and a very important factor in our Medicaid population, of course. And these conditions result in challenges to accessing resources that promote a healthy lifestyle. Next slide. Okay, so some of these challenges are fast food and highly processed foods that are heavily marketed to African-American communities. And you can see this in advertising all the time. And so I looked real quickly online at the 100 US cities with the highest, the largest number of fast food restaurants per capita. Cincinnati, Ohio was ranked number 2, and Cleveland was ranked number 9. And there are a number of these surveys, but Ohio cities are always consistently ranked highly, and Ohio overall was number 12 out of 50 states. So we have high penetration of fast food restaurants, and a lot of them are concentrated in African-American communities. And so this exposure is frequent and begins in childhood, and taste preferences do as well. So this is a special problem. Next is exposure to trauma and chronic stress. That can lead to emotional eating. We know that the highest lifetime prevalence of PTSD is in the African-American segment of our population as well. So trauma is a very significant factor. Chronic stress and allostatic load are as well, living in difficult conditions, and this can lead to emotional eating problems. Poor sleep was cited as a barrier as well. And we know that at least 3 hormones that affect appetite and weight are dysregulated with poor sleep, cortisol, leptin, and ghrelin. And so this is a special issue as well. One of the things that is often overlooked and poorly understood by other segments of the population is this issue that hair care is a barrier to physical activity for African American women who need to restyle their hair after exercise and physical activity. And so finally there at the bottom, African American women are often the heads of households, and they're expected to project this image. And there's this archetype of a strong Black woman that is kind of a paragon of strength and control and restraint. And this may really, unfortunately, de-emphasize the attention that they give to their own health, because they're caring for others so consistently and not accessing the resources that are available or prioritizing their own health. And this can lead to neglecting their health and their weight as well. Next slide. Okay, so some of the things that can help with this problem that were identified in the workshop, that community health workers can engage communities and increase knowledge about obesity promoting foods and access to obesity treatment as well, and helping develop programs for assessment and treatment. And physicians and physician groups can also partner with African American communities in countering the influence of the food industry, which is very strong, a very strong lobby as well. And on dietary guidelines, we know that those who set dietary guidelines are strongly influenced by the food industry. And some of those people are former food industry representatives or leaders as well. And to reduce targeted marketing that we know is really aimed at these communities. We also need to consistently promote messages that increase the consumption of healthy food and educate about healthy foods, and give African American communities experiences with those foods as well, how to prepare them, and how what they taste like, and really provide more access to these kinds of foods. And there are quite a number of programs going on now in Cleveland to do this, and so that's really good to see. African American women can also benefit from social supports. We know that group interventions can be quite effective in treating overweight and obesity. Implicit bias training is also likely to be valuable in preparing physicians to discuss weight with African American women. Next slide. So the group also identified that annual wellness exams are really an ideal opportunity to discuss weight with African American women within the context of their health problems, and their health goals. So this is an ideal place, an ideal opportunity to do that. And you can use the opening the door technique, for example. And one of the things that was interesting in this workshop that came out was that whites often use less direct language, more kind of indirect and subtle and a little bit oblique when we're talking about health risks and health issues, and an attempt to be sensitive, I think. And it was pointed out that in the African American community, that could be perceived as minimizing health risks and not really communicating to African Americans what their health risks really are, so that they leave that visit with a clear understanding of that. So being more direct, but at the same time being sensitive. And again, I think this opening the door technique does exactly that. And we've gone over that here in this series. Communication, again, should be empathic. That was very strongly emphasized and tailored to the patient. And there's an approach described in the National Academy of Medicine's Roundtable on Obesity that was felt to be really acceptable. So there is a model there. And partnerships between communities and departments of public health and healthcare systems can be very powerful and effective. Next slide. So medically supervised treatment, obesity treatment programs and medications need to be more accessible. There aren't a lot of these programs, and the best medications that we have for treating overweight and obesity are extremely expensive. and are out of the realm of affordability for the vast majority of Americans, let alone those in low-income situations. And so they're often not covered by insurance. And so there need to be more access and more of these treatment programs that are affordable and accessible. Partnerships, again, between communities and healthcare systems can really be powerful and guide in developing effective, culturally appropriate programs. And it's also stated that there needs to be more effort in individual communities to learn from African-American women in those communities to improve understanding, because African-American women are not monolithic. It's a diverse and culturally, regionally, economically diverse group of people. And so the assessment of obesity should be tailored to that. And it was also noted that physicians should have greater awareness that some medications can make it difficult to engage in physical activity and other weight loss promoting behaviors. Next slide. So some of the outstanding questions from the workshop were, how can physicians promote the development, clinicians promote the development of clinician training programs to effectively assess and treat this population? So clinician training programs specifically targeted to African-American women around overweight and obesity, because they have the highest prevalence of those conditions in our society. So a case could certainly be made for this. And so developing these kinds of programs could be quite effective, and there's a need for that. Also, partnerships between healthcare systems and communities could be developed to better understand obesity regionally and address these promoting factors. And as a key step, it was recommended that the group develop a set of high-level recommendations. So next slide. So there were 12 conclusions and recommendations, and I'm just going to touch on 4 of these real quickly, just to kind of drive home these messages, these take-home messages. So again, African-American women are disproportionately affected by obesity because they're exposed to more obesity-promoting factors than almost any other segment of our society. Countering these messages that are delivered by the food industry when they target these communities is very important. So we need to continue to counter those messages as best we can. Next, trauma, chronic stress, and poor sleep contribute to higher rates of obesity. And African-American women benefit from support as one strategy as well. And finally, at the bottom, African-American women are not monolithic, they're diverse. And like any other segment of our population, one single approach to each individual, the same approach is not going to work. So we really need to always keep in mind that we should individualize both assessment and treatment in this population. Okay, I'll turn it back to you, Goutham.
Thank you, Jim. Any questions or comments for Jim or for me before we move on to our cases?
I have a comment, Danette. First of all, it's a great presentation. You know, being an African-American woman myself, and then when I was at University Hospitals, I was the chair of the diversity committee, inclusion committee for the Department of Psychiatry. And a lot of complaints that I've heard from African-American women were things that you touched upon in terms of barriers and in terms of not understanding them and how to communicate with them. So to see that you did this research and you brought all of these concerns out on the table, it's wonderful to see this.
Thank you, Danette. I appreciate the comment. And you know, we did make an effort to be as culturally sensitive as possible. Curiously, we wanted to bring together leading experts in this group. 3 of our participants insisted that there be no African-American male experts in the group. I don't know what that's about personally, because a couple of my friends fall into that category and have a lot of expertise. And I think it's because the drivers of obesity must be very, very different in concerns. And there was a feeling that a group of women would be more sensitive to each other as far as that goes.
Great, thanks everyone. Just really quickly, something to mark your calendars. Our next webinar, cardio webinar, is May 25th. We just wanted to let you all know that registration will be opening tomorrow. We'll have more information to follow on that, but just a heads up. And then lastly, just the usual reminder that your post-clinic survey should be in your inbox. So any feedback from today's session is greatly appreciated. And I think that's it for today. We'll go ahead and close and we'll see you next Thursday.
Bye, everyone. See you
Bye,
next
thank
week.
you.
Bye, thank you.